Good afternoon and good morning to those that are not on the East Coast. I'm Andrea Edlow. I'm a member of the OBGYN faculty at Harvard Medical School and an MFM at Mass General Hospital. I'm the chair of the SMFM Education Committee. I'd like to welcome everyone to the SMFM webinar on COVID-19 in pregnancy, update on societal guidance and real-life experiences, given by Drs. Emily Miller and Sindhu Srinivas. Before we begin, I'd like to take a minute to share a few housekeeping notes about today's webinar. This webinar is being recorded and will be available to view on demand from the SMFM website as well as the YouTube channel tomorrow by 5 p.m. Eastern. Following the lecture, there will be a 20-minute Q&A segment. You may ask your questions, enter them in the Q&A box at the bottom of your screen at any point during the broadcast. We promise to get to as many questions as possible during the time allotted. With that, I'd like to introduce today's speakers. Dr. Emily Miller is an assistant professor of OBGYN at Northwestern and is leading their COVID OB response. Her research centers around perinatal mental health with a focus on perinatal depression. Dr. Sindhu Srinivas is an associate professor of obstetrics and gynecology and the director of obstetrical services at the Hospital of the University of Pennsylvania. She is also the vice chair for quality and safety there. Dr. Srinivas is also chair of SMFM's Health Policy and Advocacy Committee and is on the SMFM Board of Directors. Thank you both so much for taking time in this busy minute in life to educate all of us.
Thank you so much. So this is Emily and Dr. Srinivas and I are gonna kind of tag team this, and hopefully this will have more of a conversational cadence, but trying to explain as best as we can this snapshot in time on what SMFM's guidance exists and how we're integrating it into our experiences. So I want to begin. I'm assuming that all of y'all, since you navigated to get onto this webinar, are aware of the SMFM website and the fantastic resources that are consistently curated for us. But just wanted to put a plug for opportunities to follow via text, Facebook, Twitter, on the website itself, because I think this is a really great source of information for all of us to keep abreast of. Over the course of this talk, we are going to cover these topics in broad strokes. So stakeholder engagement and communication strategies, some of the systems level recommendations endorsed by SMFM, the ever controversial PPE, testing strategies, outpatient management of women who have tested positive for SARS-CoV-2, and then examples of some protocols in action, more opportunities to think through how we are integrating all of this into our processes, just to serve as an example for what you might consider at your institutions. And then we'll end with a little bit of a conversation on surge planning and hopefully leave enough time to have a fair number of Q&A.
Great. Good morning, everybody, or good afternoon, rather. Good morning for some of you. This is Sindhu. I wanted to thank SMFM again for putting together this webinar. And like Emily said, we're hoping to make this more conversational and have time for questions and discussion at the end. So we wanted to start out by just talking about stakeholder engagement and communication, because we think is really important for how all of these processes get implemented, how we're thinking about these processes, and sort of thinking about them up front really helps with the success of implementation. We'll give you some examples. I have some circles here of different examples of stakeholders. Certainly, depending on what you're trying to implement, this is not meant to be all-inclusive of all stakeholders, but obviously all of the different providers, community providers, all of the providers that are in your, that are delivering at your hospital or coming into your hospital, nurses and other staff, your ICU colleagues, since there will be collaboration with care of some of our sicker, critically ill pregnant patients with the ICU, consulting services like ID and other consultants, and that's important when we're talking about you know, medications or other recommendations, the emergency department, neonatology and pediatrics, hospital leadership, and as some examples, you know, we've definitely learned a lot over the last several weeks as we're trying to implement new processes. And as I'm sure all of you can sort of relate to, the the time that it's taking to implement things, where prior to any of this, you know, you'd spend a lot more time sort of meeting with stakeholders, really getting buy-in on certain things before you go and implement. And this has really accelerated implementation of everything, and really truncated the time frame. So it's super important to really think about, as you're implementing things, the perspectives of all of these different people. So for example, in our system, we went to masking patients and the one support person that is allowed to be present if they're asymptomatic on labor and delivery. And while we decided that sort of at a higher level that we were going to do that, to actually operationalize that is really at the level of security and our peri-op staff that are actually screening people and giving them the masks and letting them in. And so sort of including that group in the conversation of how we were actually going to do that. So while one decision was whether to do that and whether we had the resources to do that, the other part of the conversation was how we were actually going to do that. A sort of a separate example is in terms of for us at our hospital, and we're going to talk about this a little bit later with surging and just systems levels around cohorting. Some of our earlier gestational age COVID positive admissions are going to the COVID cohorted areas in our hospital, which is being run by the medicine service. And so the medicine doctors are not necessarily the ones that normally take, at our hospital at least, you know, 16 or 17 or 18-week pregnant patients. And they were a little bit uncomfortable about certain things. And so really kind of collaborating and working together. So all of these things and sort of thinking about them up front and thinking about all of the different stakeholders that are necessary to make feel comfortable in this situation is super important to think about upfront for a successful implementation of all these processes that we're trying to do so rapidly. Another thing to note is just about when you're talking about a system, whether you're making a decision for your hospital in particular or a decision that might impact other hospitals in your system, and whether the decision you're making is equally available. So this idea of like masking, for example, you know, do all of the hospitals in your system have the ability to do the same thing? Or how do you sort of think about that and make sure that there's discussion and equity and people feeling comfortable with those decisions in a broader way? And finally, just communication. You know, communication to your staff. I think MFMs are often leading a lot of these efforts at hospitals, or being persons of contact or point people for questions. And we found that, you know, communication, and Emily and I were talking about this earlier, you know, communication to staff and just being available to hear what people's fears and concerns are, and actually being able to talk about it with someone is really important for the morale of providers, the morale of staff, the morale of everybody that we're working with, and really thinking about different ways to provide that communication, in addition to sort of email and written communication, sort of huddles or different ways to, since the communication is coming out like drinking out of a fire hose at this point, it's just sort of rapid fire changes happening every day. Everything that we can do to help communicate those changes in an active way to the people that they're affecting, I think is much appreciated by the staff, and definitely helps with continued morale, positive morale, and just a positive energy around all the things that we're trying to do to keep healthcare workers safe and to keep our patients safe.
Great. So I'll delve a little bit into some of the SMFM endorsed systems level recommendations, and a lot of this dovetails with what Sindhu just described. So the first is the recommendation about coordination with hospitals within your network or region. And this is an iterative process to assess capacity and plan for guidance around transfers. These are conversations that I think many of us had in the beginning, and really need to have top of mind ongoing conversations frequently, as capacities are rapidly changing in parallel with community prevalence. So it's important to remember in our context that as resources, and that includes both healthcare workers and ventilators, are pulled, hospitals might have changing capacity to care for pregnant women and for preterm infants. And so it might be a context where a hospital previously was able to provide care for, you know, a 28-week infant, but maybe can't, given what their staff constraints are. So I think having clear mechanisms of consistent communication is going to be incredibly important, particularly for those of us that are at higher level The second large systems recommendation endorsed by SMFM is this concept of staggering staff schedules to mitigate exposure risk. And the goal here, the concept, is really to ensure that there's sufficient obstetric clinicians that are available to care for pregnant women. I think we all recognize that we are highly trained, and we have a skill set that not every physician can perform. And so trying as best as we are able to kind of preserve that skill set and make sure that there's always going to be someone that can be on our labor and delivery units to safely care for these patients, or who can kind of co-manage patients with other people with different training. So some centers are creating a patient-facing team and a home-based telemedicine team, and then kind of rotating those responsibilities at specific intervals. Others aren't doing that as explicitly, but are focused on trying to minimize the number of obstetricians in a labor and delivery unit at any given time by facilitating cross-covering of intrapartum management and deliveries. And I think important to know there's no right way to do this, but we should all be working towards diligent assessment of opportunities to reduce healthcare workers' exposure when we're able to. Other systems level recommendations, again endorsed by SMFM, and all really at the addressing the concept of exposure mitigation, are first a clinical risk assessment at the point of entry. Certainly it's imperfect to use clinical or exposure, clinical symptoms or any endorsed known exposure as the sole risk assessment, particularly in areas with higher prevalence. But patients should certainly be screened to some degree, asking about symptoms, asking about exposures to SARS-CoV-2 early in their clinical encounter, ideally by phone before they come in contact with healthcare workers, but certainly before interfacing on multiple floors within our hospital. So setting up within your hospital system what makes the most sense for inpatient and outpatient care. SMFM and the CDC also recommend, when able, that cohorting occur within each hospital. And this concept is to have women with suspected or confirmed SARS-CoV-2 infection in a restricted area of the hospital to mitigate potential exposure to other patients and staff. On top of this localization, and in addition, a goal is to try to limit the number of clinical staff that are working in these areas at a given time, again, to protect other uninfected patients or healthcare workers. And so not all hospitals can implement this in the same way, but as much as able, trying to either keep women in a private room if there's any suspicion, or have them in a designated area of your hospital, kind of taking into account the resources that are available to you. Along those same lines, SMFM does recommend that women who test positive or being evaluated for SARS-CoV-2 are placed in an isolation room, so in a private room with droplet and contact precautions. So even if they're not in a specifically designated area of your hospital, they shouldn't be in a waiting room for a prolonged period of time if it can be avoided. Finally, limiting support persons. Obviously, most of us have heard a lot about this, either personally or on the news. SMFM does support the restriction or even elimination of support persons for women who are being evaluated for or who test positive for SARS-CoV-2. For women with an unknown SARS-CoV-2 status, the presence and the number of support persons during each type of clinical encounter does need to be addressed within each specific hospital system and needs to be continually revisited in parallel with the local SARS-CoV-2 epidemiology. These are communications about policies that have to happen locally, but really important that we communicate early and often to our patients in the outpatient setting about anticipatory guidance when they do come in and how these policies might be fairly dynamic. So moving on to PPE, I want to start with women with suspected or confirmed SARS-CoV-2. And so women with suspected or confirmed SARS-CoV-2 should all, and this is endorsed by SMFM as well as SOAP, wear a surgical mask at all times as tolerated. We all recognize that there are some impracticalities in the second stage for women who have respiratory morbidity keeping a mask on, but as much as is practically able, a patient should keep her mask on. Healthcare workers should also use a surgical mask for all close and prolonged patient encounters for women who with suspected or confirmed SARS-CoV-2, and that's both intrapartum as well as postpartum. And then for all women with suspected or confirmed SARS-CoV-2, an N95 should be utilized during any aerosol generating procedure or AGP. An example of an AGP is intubation. That seems very clear. How we operationalize this within our health systems is definitely unique because we can't always / ever predict when intubation needs to occur in the setting of a cesarean. And we also all recognize that when conversion to intubation is happening, it's typically in the midst of a fair amount of surgical instability. So it may be prudent to have surgical teams go ahead and wear an N95 when scrubbing for a cesarean, just given our imperfect ability to predict when conversion to general anesthesia will occur. An area of fairly significant controversy over the past few weeks has been whether the second stage of labor and a vaginal delivery is an AGP. The CDC hadn't clearly stated that these were aerosol generating procedure, but important to know that SMFM has advocated for some clarity, and there is a letter on the SMFM website documenting the conversation that's been held with the CDC and the support for the use of N95 masks in the second stage for women with suspected or confirmed SARS-CoV-2. And then finally, while there's been a lot of conversation that is about masks and which masks we need to wear, protection from SARS-CoV-2 does not begin and end with face masks. All of the components of appropriate PPE are essential, and this includes eye protection, either goggles or a face shield, a gown, gloves, effective hand hygiene, and proper donning and doffing. I think we as MFMs have a really large role to play here on our labor floors, ensuring that all of our healthcare workers feel confident and comfortable with proper donning and doffing procedures. Informed by the local epidemiology, healthcare workers can consider using droplet and contact precautions for all prolonged and close patient encounters when SARS-CoV-2 status is unknown. I think this is happening in many of our hospitals already. I think there's an area where there is no clear guideline or recommendation, and that's whether to wear an N95 in all deliveries for women with an unknown SARS-CoV-2 status, or whether a surgical mask is sufficient. And I think it's important for us to remember that the reason there's no clear guideline here is that decision has to be informed by community prevalence and can be balanced perhaps by the availability of SARS-CoV-2 tests. So for example, if a woman is asymptomatic and she had a reasonably reliable test and that test was negative, perhaps a surgical mask is sufficient. But if there's a high community prevalence and testing is not available, an N95 for all deliveries is a reasonable clinical decision, in my opinion. But we can't have specific nationwide societal guidance because there are so many dynamic factors at play with what is the safest route. And again, I can't emphasize enough, the mask is only a portion of the requisite PPE.
Great, so that sort of dovetails into our next topic, which is testing. And I want to echo what Emily said, is that the mask is only part of it. And so the rest of all of the PPE that she showed, and particularly the doffing process, where healthcare workers can get contaminated if they're not doffing appropriately, is also really super important to pay attention to. But as she said, the sort of balance of N95 use and how that sort of is interplaying with testing may drive local decisions around the use of it and which patients on labor and delivery or in other areas of the hospital where healthcare workers are using N95s or not. And so from a testing perspective, which has obviously been a really important and sort of hot topic, there's several tests available out there. This is not meant to be completely all-inclusive, but just give a big overview. Most of it's by, it's PCR testing that's done by nasopharyngeal and oropharyngeal swabs, nasopharyngeal or from aspirates if patients are intubated. The availability of these tests definitely varies by location. A lot of hospitals, larger hospital systems, have even developed their own in-house test. These are a couple of different platforms, and you can see that the things in parentheses are the turnaround times. And so, how long it takes to get a result back. and which tests are being used and how many tests can be run per day and the volume in your hospital is important things to consider in terms of how that balances with PPE availability, and that will determine or dictate the strategy for how these two things are coming together in each hospital. There's also this sort of option for send-out testing, which can take several days, although that turnaround time for these send-out tests has also dramatically decreased since in the last few weeks. There's a point of care test that's also out there that's not on the slide, that's, you know, within 10 or 15 minutes. I think validation of that across different areas is still occurring, and I don't think that that's up and running at most places at this point. And reagent availability has really been a major problem. I think you can flip slides, Emily. Sorry. And so from the perspective of just sort of, you know, to sort of go back to the dreaded 2x2 table for just a minute, you know, when we think about disease prevalence, and Emily mentioned this, the sort of how testing is being used and in what situation, but also just sort of prevalence related. So in low community prevalence settings, testing everybody might lead to some false positive tests, and the implications of that need to be considered. When we talk about this test in particular, I think what people are very concerned about is the false negative rate, right? So that's the fact that you do a test and how much that test dictates your management, your PPE use, all of those things, and that potential that it's negative. And a couple of reasons it could be negative might be not necessarily the prevalence of community disease, but actually the timing in which you actually did the sampling in relationship to the patient's symptoms. Right? So people talk about at this point that really 24 hours or maybe a little bit longer prior to symptom onset, we should be able to detect PCR detect the virus. But if it's done much in advance of that, you might get a false negative we do, and that might come out 2 days or 3 days later. And so I think it's important to think about how we're utilizing testing, and when we do get a negative, that precautions around masks for patients and masks for healthcare workers, surgical masks, and other sort of diligent techniques that have been recommended by SMFM and the CDC around hand washing and other things still need to be really, really diligently followed, even in the setting of a negative test. And the other sort of issue with false negatives could be a sampling strategy. So, you know, you're sampling the nasopharyngeal, you're doing a nasopharyngeal swab, and if that swab is improperly collected, that could also lead to a false negative result. But the prevalence of disease in the community and the balance of the availability of tests and the availability of PPE need to be sort of broadly and really thought about together in terms of the optimal strategy at each local place for how to be the most thoughtful about protecting healthcare workers, especially in these settings of asymptomatic patients. And I'll give sort of like an example. We actually had a patient that came in for a completely sort of routine obstetrical reason, having reported no symptoms, and we are screening everybody like most places are in terms of symptoms, and was being admitted for that obstetric reason, had a mask on, and the healthcare workers all had masks on, and like 6 or 7 hours into her admission, she had a low-grade temperature that was really unexplainable. And then when we went back to talk to her, she had she thought were allergies, and so really didn't mention it. And then we sort of elevated her to a person under investigation status and swabbed her and, isolated her and all of those things. And she actually ended up being positive. And so that's, I think, the exact example or one of the types of examples that healthcare workers are concerned about in terms of an asymptomatic individual and your risk of exposure as a healthcare worker. But because she was masked, we were masked, and you're really kind of paying attention to all of these diligent factors each time, your hand hygiene, even in the setting of like an unknown or negative patient, that you're just always sort of diligent about these things. It was deemed by by all when we evaluated all of the providers and nurses and everybody that were in that room prior to knowing that it was a very low to minimal exposure for anyone, just based on length of time, distance from the patient, and just the fact that everybody was masked and she wasn't actively coughing. So just a sort of real life example of these encounters are happening, but I think the diligence all the time and then really thinking about how to utilize testing with PPE, or really thinking about that sort of together in a strategy that makes sense for your local institution is really important. So flipping gears for a minute to the outpatient management of COVID-2 patients, you know, it's been reported really in non-pregnant patients and really similarly now in pregnant patients from the New York experience that many patients rather with COVID-2 can really be managed as an outpatient. So they're not reporting symptoms or having clinical criteria that is requiring admission. And that's really over 80 or 85% of patients can be managed as an outpatient. And what's important to really remember though is that creating a system of some sort, depending on the volume and your institution or your hospital, of checking in with these patients relatively regularly at some point, in addition to giving them some very specific instructions, and whether that's creating, standard instructions for patients who are being discharged or who are being evaluated for COVID-2 is super important, as there does seem to be sort of almost two phases of the disease where, initially patients might be a little bit mild, they might even feel better, and then at this like sort of day 6 to 7 to 9, sort of in that midpoint of the 2 weeks, some percentage of patients report getting much worse and having worsening shortness of breath and inability to breathe. And so really educating patients about those symptoms and being cognizant of the fact that some percentage of people may get worse, and having an ability to escalate those patients to being able to come into the hospital. And then, how do they come into the hospital and all the systems required to notify the hospital that they're coming in so that everyone is ready for that patient with the right PPE, the appropriate room and isolation, all of those things. But I think just most of these patients, the pregnant experience so far seems to be very consistent with the non-pregnant experience, which is that most patients can be managed as an outpatient. But just thinking about how to systematize follow-up for those patients and education around the fact that some percent might get worse. And it's seemingly very hard to predict who those patients are going to be that are going to get worse, at least at this point.
So we wanted to just give some real world examples of how we're operationalizing the concepts that we've been communicating so far into development of some of our internal protocols. And so I'll give you an example of one we've been working on where I am. And I'm not giving this as an example of something that is right and a source of truth. It may not apply in your setting, but at least walking through the concept will hopefully help be useful to some folks on this webinar as they're thinking through their own processes. So some concepts that I think are really important for us to keep in mind are we have to be nimble. The protocols that we're developing today are going to be outdated in 2 days, and that's totally okay. We have to be willing to revisit our recommendations to align with the dynamic state of science and the resources that are available to us, and those are constantly changing. So if you have a protocol you developed last week and you're still using it, I'd really think twice about if that's the right course of action. Just critically evaluate every few days what needs to change. The second is being familiar with guidelines as they come out. It can certainly help you frame what your needs are and how we communicate to hospital administration. But remember that they're just guidelines and they have to be applied to our local context. And so some resources that have more PPE relative to testing or vice versa, or some that have neither, you really need to think creatively about how these guidelines fit into your context and your epidemiology. Stakeholder, Sindhu mentioned before, and I think these are, again, just some examples. This is not comprehensive. The stakeholders that are involved might not agree with their professional society's guidelines, and they might want to make changes based on some emerging evidence that hasn't had time to get incorporated into their guidelines. And so it's really important to engage with them as data evolve. It's also different lens for, some of our obstetricians that are in private practice versus some of our obstetricians working in FQHCs, and the lens in terms of the social determinants that their patients may or may not face in terms of all of these changes. So it's really important to have all of these perspectives in mind as we're developing protocols. And while things have to happen quickly, it doesn't mean you can't have quick reach outs via all of the telecommunication that we're doing now with each of the stakeholders. And I think it's easiest, and I'll give an example of this, to start pretty much in all areas where you're developing a protocol. We can all agree at least at some consensus, and then you can dial it back from there and get into the more nitty gritty, and then developing clear lines of communication and communicating often. You really can't over communicate in this setting. I think people are feeling, at least in our setting, like they're not getting the information from their typical lines of communication, and we really want to make sure we're getting in front of it as opposed to trying to catch up behind people feeling like they were caught unaware. So an example, and again, this is just kind of one of the many examples we're all working through, is a protocol about when we would consider a woman with a prior positive test for SARS-CoV-2 as quote unquote cleared. We have CDC guidelines about that. There's also AAP guidelines that have been released that inform when we could consider it safe for a baby to be reunited with its mom. But it's important to realize that some of those guidelines have to do with testing and some of them are clinically based. And in my setting right now, it's rapidly changing, but testing has been a scarce resource. And so we needed to go with the clinical guidelines. But as we started to walk that out with our stakeholders, our community OBs understandably really wanted to make sure that there was a negligible chance of ongoing viremia before they were allowed to re-enter into their office settings. They don't have environmental services to help with terminal cleans. It definitely gets a lot more cumbersome to shut down an office for long periods of time. So integrating that perspective. Hospital healthcare workers and all of us want the right PPE to protect ourselves against any potential prolonged viremia, specifically in the context of the high exposures that we face occupationally. As someone that's involved in operations on our cohorted COVID unit, along with our OB anesthesiologist, the idea of keeping women who had a prior SARS-CoV-2 test a long time ago on that cohorted unit has huge throughput issues. It's great. We have half of a floor, but it's only half of a floor, and that can fill up pretty quickly. Our pediatricians are constantly being inundated about case reports of neonatal infection. That concerns them a lot, and so they might not be aligned with the AAP guidance. And then our patients, we have to remember, it is really alarming to them to be told a support person may not be able to be with them if they test positive, or they may not be able to reunite with their baby right after delivery. Remember, these are the same patients that had really long birth plans 3 weeks ago, so it's really a whole different context now. And so we, all started in conversations with, hey, look, we're all aligned with this idea that we really want to advocate for PPE for all of us in an aggressive way until we know that viremia wouldn't be present. And so I'll share with you what we've come up with. This was, as of yesterday. Again, this isn't something that is right or something that may not apply in your setting, but for women with a prior positive test, if it's been 40 days since their last positive test or symptoms, they become a regular labor and delivery person. That was informed by kind of evidence around the longest sustained viremia. That might not be the number in your, that you can apply because you might have more restricted PPE, and that's very reasonable, but this was where we landed. We then go with the AAP and the CDC guidance on clinical clearance, but we added in this positive test due to a clinical wrinkle that we don't have to go into. If they're within that window or they're still in this not cleared symptomatically window, then they would go into our COVID unit. But if they are cleared, then our pediatricians were a little bit uncomfortable with that day 8 for a woman who has ongoing cough, but a cough that's improving, having they're, co-sleeping with their baby, for example. And so we developed this tiered system postpartum, where from a throughput standpoint, a patient can be delivered on labor and delivery. She's in a private room. The baby can room in with the mom, but we make efforts to minimize direct maternal infant contact. The patient consistently wears a mask, et cetera. And so that was kind of the negotiation that we had to allow our throughput to continue to function, but to make sure that we were kind of stepping up the care for these infants and augmenting the education for our patients around protecting the neonate. So again, I use this not as an example of a source of truth, but just an example of a process that had we landed on something that I would have decided by myself, it would not have ended up being this. And it would have rolled out and we would have had a lot of people very upset. So this is a place of consensus that if everyone integrates into it, we put this together in 48 hours, and it's working reasonably well so far.
And I was going to say that that we actually have something very similar, and our neonatologists and pediatricians were comfortable with that sort of 7-day, the sort of clinically cleared infection recommendation, and so we didn't do that tiered approach that Emily just showed from the 7 to 14 or the more than 14, but that's sort of a, those are the types of things sort of locally that we have to work through as we're all working through. And I think the nimbleness factor can't, as I'm sure you've all experienced, we're all experienced. This is really a lot of hard work, a lot of rapid change based and things that are changing as we get more information, but from the onset, sort of a lot of uncertainty. And so being as communicative, can't over communicate, I couldn't agree more, and being nimble about processes that are really changing pretty rapidly and how those are being communicated is super important. From a surge planning perspective, I know a lot of people have had questions about sort of surge planning. And so surging, right, is sort of defined as when patient volume challenge or exceed a hospital service capacity. And there's so many things to consider in surge planning. So we're going to go through sort of a few things, and definitely not meant to be all inclusive, but hopefully you're going to bring up some things to consider. So the first for us is sort of around equipment and just sort of cohorting. And Emily mentioned cohorting, and that is sort of recommended if able to happen. So an example for us was we have a cohorted area that we've created for our antepartum patients, and we've decided that patients over 22 weeks with COVID-2 would come to our unit. Patients less than 22 weeks would be cohorted on the rest of the hospital's medicine unit for COVID-2. But then we were talking about the rooms that they're going to be in are rooms with continuous monitoring capability, and if all of those rooms get taken up by antepartum COVID-2 positive patients, we would have no monitors left for antepartum patients who didn't have COVID-2. And so we needed to rent extra fetal monitors that were portable. So it's just an example of just walking through with your nursing leadership, your engineering staff, can rooms be made negative pressure, recommended, but definitely not required. So different stakeholders in each of these conversations. We have several ICUs that have been created, some of our standard ICUs and then extra ICU areas of our hospital. When we started, we have several ICU patients who are pregnant that are admitted, and we wanted to make sure that if that number were to go up, that we didn't have pregnant patients going to a variety of different ICUs based on bed availability. And so that's a conversation that we're having with the ICU teams and hospital admissions around cohorting pregnant COVID-2 positive patients within a single ICU so that there's clear, multidisciplinary care happening with that ICU team, guidelines that are being developed, and then just communication and our ability to respond to one specific place versus going across in different areas of the hospital. Are patients going to be coming to you from other facilities, or are you going to have to transfer patients to other facilities? So if you're part of a bigger system, are all of the COVID-2 positive pregnant patients that are being transferred to a higher level facility going to come to the same place? for hospitals that maybe don't have the same level NICU. So we have one hospital where the respiratory therapist in the hospital that takes care of the NICU babies also is really taking care of all of the ICU patients in that hospital. So if they surge, they're going to need that respiratory therapist to be deployed to other adult floors. And the NICU is concerned that they might not have a respiratory therapist regularly to help with the less than 28-week babies. And so they had reached out sort of wanting to talk about that in advance. So really thinking ahead about all of these different things, how one thing might affect something else. And the best that we can do is to try to think about these things in advance and be prepared for them as best as we can. And really thinking about equipment we need in advance, space that's needed in advance, methods of communication, or how to create open communication so that it can happen in a timely fashion when it's actually needed to happen. From a staff perspective, as Emily mentioned before, trying to minimize staff exposure and even cohorting of staff, or planning around minimizing the number of staff that are working or exposed at any time, how telehealth has really influenced some of that as well. On labor and delivery, there aren't really lots of other people in the health system, other doctors of other specialties that can just hop on labor and delivery to help if needed. But what we've been talking about and are doing is that our non-OB faculty and fellows, so GYN subspecialists, in some places those subspecialty fellows might already be doing obstetric call or doing obstetrics, or you might not have fellows but have GYN only attendings or GYN subspecialists, and trying to think about how potentially to incorporate them into a surge plan. We've incorporated them on the earlier side to get people comfortable sort of being back on OB as like an extra provider. So they're still with general OB-GYNs and MFMs on labor and delivery and on OB. But that's a potential strategy if at your institution you have the capacity to think about how they could be incorporated from a staff perspective. And then Emily, I think you wanted to mention something about the sort of ethical framework.
Yeah, I think
about this.
Hopefully this is more anticipatory planning than any of us have to actually implement. But I do think we've started conversations, and I know many other hospitals have, about what is the ethical framework if there do become issues with resource allocation, specifically ICU beds and ventilators. Obviously, we all recognize that there are differences. There are no great validated scoring systems specific to prognosis after COVID infection that requires intubation and pregnancy that align with mortality risk. But how we equate or don't equate pregnant women to the general population is really important. I also think it's important to really start these conversations if this even is a remote possibility in your area, because I think the only thing scarier and worse than starting to have these conversations and starting to systematically think through how we compare short-term and long-term prognosis between patients is deciding to do it on the fly, because that's when we know implicit biases can creep into our decision-making, unfortunately. So in order to really have an eye toward equity, this is something that health centers should be really critically thinking about and engaging your ethics teams with. And I think with that, we certainly wanted to leave a fair amount of time for questions and answers. So we'll kind of wrap up with the didactic portion there, and then hopefully we can kind of have a conversation about what questions you guys are facing on the ground.
Thank you guys so much. That was incredibly useful and just really pragmatic for everybody. We got a lot of questions, so some people were asking them in the chat. If you don't hear your question being answered, if you can also enter it into the Q&A box, it helps me keep track. So there were some questions that you guys touched on, but about universal testing and universal rapid testing, especially if you don't have that capability to do universal testing or a point of care test with a rapid turnaround time, is there utility to surrogate lab markers such as CBC, LFTs, et cetera?
We are implementing universal testing today. So I can certainly speak a little bit to this. I think one, the rapid test that's available, the only one that I'm aware of, there could very well be more, is the Abbott Alere. And that's a point of care, 7 minutes if it's positive, 13 minutes if it's negative in terms of the turnaround. It can only be one specimen at a time. We had those machines, the touted sensitivity is 95%. We did a validation at our center and found that sensitivity to be far from that. And in fact, in a range that was clinically not useful. So we have not moved forward with it, but I think the lesson there is it's incredibly important to validate whatever test it is with your existing population and make sure you're troubleshooting before you're actually using that information clinically, because I shudder to think of the path we would have gone down. I think we also have to think through what's the role of a positive test, and in my mind it has to do with PPE conservation. And Sindhu spoke a little bit about the negative predictive value. We anchor a lot to sensitivity, and that certainly is the test characteristic that we need to anchor to, but what we really care about from a healthcare worker standpoint is the negative predictive value. So if somebody has a negative test, what is the likelihood that she is in fact SARS-CoV-2 negative? And I just, whatever, back of the envelope calculations, if there's a 5% prevalence of SARS-CoV-2 in an asymptomatic population in your community, I'm just making that number up, then the negative predictive value from a negative test is going to be 99%. And so thinking through, is that sufficient enough? It is for us to say, hey, we could dial back on the PPE, and maybe in that setting, we would not use an N95 at delivery. So I think that's how we're integrating testing and universal testing into our processes. I would personally not feel comfortable using other lab markers to try to make a clinical assessment about whether someone is or is not SARS-CoV-2 positive. I think they can inform your clinical acumen about whether you would test, but I wouldn't use those intrinsically to make an assessment about whether they are infected. Sindhu, I don't know if you have.
Yeah, I agree with that. I don't think that any of those lab values like CBC or creatinine or things, while they can be, they're abnormal in people that have SARS-CoV-2, I don't think that they can be used in replacement of a test. And I think that you sort of described it very well. We're considering universal testing. We're thinking about it, but just the importance of the community prevalence and your PPE rate. And if you have a really high negative predictive value, then the idea would be that a negative test would be good enough to then not use PPE. And that would be the point of doing it. I think the other issue is that if you get a negative test and then 2 days later somebody is febrile, that I think, kind of, again, having that sort of thinking about the clinical context for that patient and whether they need to get, reevaluated at that point. And so I think those are sort of like real world clinical things that are coming up. So a negative test in the moment sort of dictates what you might do in that moment, depending on the negative predictive value with your community prevalence. But 2 days later, a different clinical situation comes up. That's a new situation that needs to be thought of differently at that time.
Thanks. That's really helpful. Just to stick on the same kind of set of questions, there was a question about, it sounds like you guys at your institutions are not retesting to ensure that a COVID-19 positive patient has converted to negative. You're just following days from test positivity.
Right, that's what we're doing.
Yes.
Because of challenges we've had with testing availability and turnaround.
Yeah, and the CD, there are two different approaches, right? So there's the symptom-based approach and the testing-based approach, and you can use either. And I think what we don't 100% know, it seems like what is being talked about is that the viremia can be detected for a little bit longer. And so whether that translates into, like if a PCR is positive, whether that translates into infectiousness I think is kind of what's not completely known. And I think, at least from the recommendations around the symptom-based sort of clearance, I guess theoretically you might test somebody who meets that criteria and they maybe could be positive. But I guess the thought is at this point that they're not infectious, given that sort of clinical criteria. So it is a balance. And I think we'll learn more as people do more testing in negative patients and figuring out the real time course of how long it's detected and infectivity rates.
Thanks. I think that answered another question about sort of infectiousness correlating with test positivity. There are a group of questions about labor and delivery management. So people are asking, just on the ground, are you seeing any early warning signs of asymptomatic patients becoming symptomatic in labor? If so, does labor seem to be worsening the course of the disease? And how do these patients present?
Yeah, we're testing women with, I guess I should begin. We've had a little bit of a bottleneck with testing. And so it's really hard to understand the denominator because we've had to be a little bit restrictive. But intrapartum, for people who have more of an atypical choreo, those are people we've tested. We haven't had any that come back positive, but I know the published case series from Columbia indicate otherwise. And so I think it's important for all of us to have at top of mind, changing symptoms intrapartum, things that we might have called choreo, but kind of, furrowed our brow at 3 weeks ago. I think there should be some clinical suspicion for SARS-CoV-2.
It doesn't seem, I guess, sorry, back to that, the part about does the process of labor seem to trigger progression of the disease? I don't think that we know that or have sort of seen that reported that someone with mild symptoms sort of get worse because they're in labor. I think that part of this is around the disease course itself, and that women who have mild symptoms like 7 days in sometimes can just get worse, just part of the disease progression. And so I'm not sure that it's really a labor trigger versus just the natural progression for some people with this virus.
And people have asked, are you monitoring patients any differently on your L&D because of COVID? I don't know if that's specifically COVID positive or all patients, such as more frequent respiratory rates and O2 sats in labor or things like of that nature.
If we admit somebody who is a person under investigation, so meeting like sort of symptomatic criteria for testing or who are positive, if they're being admitted for respiratory reasons, like for worsening COVID-2, the idea would be to manage as many of them outpatient as possible. But if they need to be admitted from a respiratory perspective, we are doing continuous pulse ox for those patients, mostly because they're being admitted for a respiratory reason. But not anything different for positive or PUI patients who are in labor or being admitted obstetrically, but that are symptomatically okay, meaning normal respiratory rate or like normal O2 sat. Just being mindful of the potential for worsening, but not doing anything up front that's different if they're being admitted for an obstetric reason. I don't know, Emily, if you have any other thoughts.
Yeah, it's I think a really great question. We haven't had an opportunity to test asymptomatic folks or people who aren't, requiring admission to the hospital for respiratory issues, but so I don't think we have enough experience to really inform that, but I think it is something worth considering, just having it kind of at the top of your mind that respiratory symptoms could evolve, so being a little bit more vigilant. But we weren't planning on doing continuous pulse ox in labor for asymptomatic test positive women.
Yeah, it seems that the respiratory symptoms, even in the non-pregnant patients, may even be more helpful than the pulse ox itself. So if someone's not having respiratory symptoms, I'm not sure that I don't know that there's clear guidance on the utility of pulse ox in someone who's asymptomatic.
Thanks for clarifying that. Along those lines, people are asking about sort of oxygen saturations that should be our goal in pregnant patients, both intubated and also I'll extend that to not intubated?
We're using an oxygen goal, a saturation goal that's a little bit higher than what would be used in a non-pregnant population. So we're considering admission for patients that are having an O2 sat at rest that's less than 95%, which is a little bit higher. Our medicine colleagues and emergency medicine colleagues are using more like less than 93% or around 93%. So we're a little bit higher than them in terms of considering admission. I think that partly because of trying part of that oxygen dissociation curve and trying to have a SAT, peripheral SAT, that is allowing for adequate fetal oxygenation. From an intubated patient perspective, I think that's a lot more complicated. You know, the goals are similar, but in some of the sicker patients where different modalities are being tried, like proning patients that are really sick, trying to balance what their FiO2 requirement is, and even doing permissive hypercapnia sometimes, and what their pH goals are. I think those are very like individualized conversations about those particular patients and gestational age and goals of care, and conversation with the, you know, your with MFM and ICU and the patient's family as well. And so I think that's hard to give a like sort of exact criteria because every situation is so different.
Yeah, and just to add, we're also using 95% as our goal, and that's aligned with our medicine colleagues right now. I'm sure that will evolve. The other thing that I've learned from rounding with them for a few times, something that I hadn't done a lot of on our antepartum floor before, is ambulatory O2. So certainly before sending someone home, having them do an ambulatory O2 sat to get that data to inform whether that they can be safely discharged home, because we're finding a fair number of women will desat pretty significantly ambulating in the room, and then we keep them a little bit longer.
That's a really good point, Emily, because there's a lot of, you know, you can have an ambulatory sat at rest, but given the sort of what's the lung pathology in this virus, the exertional hypoxia, or even like, you know, with even minimal movement can lead to a desat. So we're also doing some ambulatory SATs prior to safety for discharge.
Great, that's really helpful. A couple of questions about equity. People are asking, are data available on race, ethnicity, age on affected pregnant women? If not, why not?
Sorry, can you repeat that? I had a little Zoom issue.
Oh, sorry. People were asking about, are data available on race, ethnicity, age on affected pregnant women? What's that experience so far in people's communities? And if not, why are those data not available?
In terms of prognosis, I don't know that I've seen anything, and I think that's literally because we're 3 weeks in to the pandemic, so there's just not a lot of data to begin with. But I think we all have an eye toward, you know, the publications that are coming out about racial ethnic disparities and overarching mortality related to SARS-CoV-2. So I think it is something, at least internally, we're very heightened about how care algorithms are applied, but I don't know of any specific outcome data that have been able to be stratified just because of small sample sizes.
There were many questions about masking. I think you guys probably gave the best guidance when you just said it depends on people's own kind of ability to have broad use of PPE, exactly what's recommended, but lots of questions about N95 mask use for the second stage, what's considered aerosolizing, and then is a surgical mask different than an isolation mask, meaning a two-tie surgical mask? Is that recommended over just like those ear hook masks for non-N95 mask wearing?
Our infection prevention is using those synonymously, a surgical mask that has the two ties and the ear loop, in terms of their protection. So I haven't heard otherwise, and I'm not aware of resources that indicate that there's a differential there.
I agree. We're treating them the same as well.
People are asking some questions about have people been hearing that early delivery for critical maternal respiratory perspective can be useful from a maternal standpoint?
I've heard anecdotes in that direction, but I don't have personal experience here yet. I think, being cognizant of the potential for fluid overload and exacerbation of ARDS has to be top of mind, but I have heard that, uterine decompression has, again, very anecdotally, been associated with improved ability to ventilate case by case.
People have asked if patients need to be transported from one setting to another, such as from their L&D room to an OR. Are different teams transporting? What are you doing with regard to PPE for those transports, et cetera?
So there's a process that our infection prevention has recommended for transport. That's the sort of in the room, there's sort of unplugging of the bed, wiping down of the bed by people that are donned in all the appropriate PPE, and then a handoff to people outside of the room that are donned in PPE to accept that patient, cover the patient with a sheet, and then actually transport the patient, wipe the bed down again and transport the patient. And then the people that were in the room are doffing in the room as they're supposed to. So that's definitely a process that's worth talking through and thinking about ahead of time, and even simming. When we did a few sims on that, that's actually one of the things that took the longest, and we created sort of a more streamlined version of who would be doing those roles ahead of time, because if a patient in labor, understanding that it's very hard to really do a sort of a stat, anything on a COVID positive patient, given the sort of first and foremost, everybody needs to put on appropriate PPE, but trying to think about that process, if you were to have an emergency, like doing it as efficiently as possible, but as safely as possible is important. And so we've actually simmed that, which is a great question, but we've simmed that a couple of times.
Yeah, we did the same, and I can't underscore how valuable that was, because it is such a different process than what we're used to in terms of flying out of the room down the hallway, and also simming things like a cord prolapse and how that would be handled, I think has been really helpful for us to just think through the process before it happens.
There have been 3 questions about stillbirth. Patients who present with stillbirth, if they don't otherwise have symptoms suggestive of SARS-CoV-2, would you test them? Have you heard anything about that?
I don't know that there's any guidance on that, but it's an interesting question.
I agree. I don't know that. I don't know one way. I guess I don't have a strong feeling one way or another of that being an explicit indication for testing. But it is an interesting question.
Yeah, interesting. I asked it because a few people have asked. Maybe one of the last questions, are you seeing any demographics or pregnancy-related risks emerging to help predict pregnant patients who will require intubation compared to others?
I don't think, at least in our institutional experience, I'd have enough data to make any kind of accurate assessment of risk prediction, but we're certainly seeing women with comorbidities having kind of longer durations of their admission, whether that's because it's actually needed or because we have, that's a clinical decision that is informed by those comorbidities rather than a result of the comorbidities. I can't answer.
Maybe one last question, sort of loosely centered around perimortem C-section. Sort of how are you approaching these types of scenarios? Are you trying to avoid those at all costs?
Yeah,
I
think I will say that our intubated patients tend to all whether it's
Hi, everyone. This is Gabby. I think we may have lost Sindhu. I'm going to give her a few minutes to log back in.
Oops, sorry. I think so too. Emily, did you, or if you're still there, did you have any kind of protocols in place or thoughts about trying to avoid perimortem C-section and how you might approach that in your patients?
I don't think our guidelines in terms of, when we would perform it, I think the only difference is making sure that our healthcare workers are able to properly don PPE, but I think otherwise our general guidance is important to follow. I don't think there'd be anything intrinsically different about COVID aside from the PPE that would change how I would manage performing a perimortem.
Yeah, I think at least what we've talked about in our group is just because of some of these anecdotal data about maternal improvement in status if there's no kind of response on the vent and worsening on the vent compared to other diseases, we might consider an earlier, Sindhu's back now, good.
Yes,
Sindhu, we're still talking about perimortem C-section, kind of trying to avoid it. Like, would you just move to an earlier delivery at an earlier GA than usual if the mom status is worsening to try to not get in that situation, or what are you guys doing?
Sorry, I misunderstood the question. Yeah, we would, I think if we were getting to a point where we were maxed out on vent settings that we don't have an ascribed gestational age, because I think that has to remain individualized, but we would certainly, I would move toward delivery if we really had no other options. I think that's an opportunity to improve ventilation.
Got it.
Yeah, I agree with that. I think, the things that are in our toolkit are to improve a patient's status would be things like trying to prone a patient if that helps, and you'll know pretty quickly if that's going to help. ECMO has, definitely been brought up in terms of improving ventilation, and at what gestational age you would maybe try ECMO before delivery, I think is sort of an individualized discussion and has to also balance the risk of surgery, a surgical intervention to the patient at that time, depending on their status and whether a surgical intervention might be lead to a worse outcome. But I think in general, definitely delivery and relieving the gravid uterus in terms of improving ventilation is part of potentially resuscitating a patient. I think perimortem section is, kind of from a PPE perspective and how quickly you're going to be able to actually deliver a baby to improve circulation for the patient is going to be limited by the need to appropriately be protected when you're doing that. And so, trying to think about that in advance in this situation compared to others, I think is very important and definitely something that we've been talking about.
Great. Well, I think it's getting a bit late, and so I just want to respect you guys' time because you were so generous to prepare this on short notice. Thank you again. It's been incredibly useful, I think, to all of us. And if your questions weren't answered, you can definitely feel free to email me, Andrea Edlow, or Gabby with your questions, and we can try to get them answered. And these slides will be made available along with the recording tomorrow at 5 Eastern.
Thanks so much.
Thank you, guys. Thank you so much.
Thank you so much. Bye.